Good evening to everyone present here with us today. This is Rion from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Bharti Kalra. Ma'am is MD Gynec Consultant at Bharti Hospital, Karnal. With the help of ma'am and her wonderful insight, we will be taking a close look on today's topic, which is non-surgical approach for stress urinary incontinence. Now, without any further delay, I would like to welcome ma'am at our forum and would like to hand over the session to her. Over to you, ma'am.
Thank you. Mm. Hello, dear friends. It's a great opportunity to share the knowledge of management of non-surgical approaches for the stress urinary incontinence. Someone may be thinking, what's big about it? We don't get it the problem, so why should we worry about it? But if we ask our patients and in routine, even if they don't volunteer the information of in urinary incontinence, but if we ask them empathetically, they will let us know that they have this problem at least once in their lifetime. Nearly 40% of women are affected frequently by the problem of stress urinary incontinence. So let's quickly go about it. What is stress urinary incontinence? So, more so, what is urinary incontinence? Urinary incontinence is involuntary or abnormally urine loss. Most of the time, we are continent, means whenever we want to pass urine, only then we pass it. But at times, the embarrassing situation happens when it's out of our control. We may leak just one or two drops or the entire urine, and which is socially as well as psychologically very embarrassing. So that is known as urinary incontinence, and that may be associated with the lower urinary tract symptoms like storage problem. Some women may be saying, or even for that matter, men may be saying, I can't hold urine for a longer time. Or the other may say, I get difficulty while voiding urine. At times it comes very fast, and at times it comes just dribbles. So the different type of urinary voiding problems or storage problems are there, which may manifest as one is the urge urinary incontinence. That means involuntary leakage with urgency. You get the feeling of passing urine and suddenly you get leakage. And another one is stress urinary incontinence, which is the most common one, seen in mostly 50% of persons affected by any type of urinary incontinence. This is the involuntary leakage on specific activity, at times with sneezing, coughing. This is also known as anatomic incontinence, even on laughing. So, laughing is restricted, those who are suffering from this situation, or they are unable to lift heavy weight. If they are just picking up something, even not going to gym, even then they get this problem that when they sit, they just squat and they pass urine, they leak one or two drops of it. So, but another condition is in which someone may get mixed type of incontinence. The patient says, Doctor, I get both kind of features. Whenever I feel like going to washroom, suddenly urine leaks. Or if I start just sneezing or laughing or even jumping, I can't jump, I can't skip rope. How can I lose my weight? So these kind of usual OPD problems we find. So that kind of incontinence is mixed urinary incontinence. And there is another type called as the overflow incontinence. Means bladder has capacity, the muscles are relaxing, the bladder fills a lot, and then because of the pressure in the bladder is more than that of the which the our urethra urinary opening uh, can hold, so that just a few drops leak over it, and still the bladder is full. So all these result in lower uterine symptoms and small amount of urinary loss. And overflow incontinence is commonly seen with middle-aged or elderly males, those who suffer from benign prostatic hyperplasia. And there another type of urinary incontinence is functional incontinence. There is no urge incontinence, but patient doesn't get time. She gets an urge. She doesn't get in time to reach the washroom. Maybe because of her immobility, at times the arthritis may be the culprit, or there are a few barriers. The washroom is far off from her bed. By the time she gets up from the bed and reaches the toilet, she gets the leakage of urine. So another condition is overactive bladder, and often used to describe the urinary incontinence. Uh, some may call the urge incontinence is equivalent to overactive bladder, but it is seen that in overactive bladder, 80% may present with the urge incontinence. So the symptoms are urgency, frequency, and nocturia. Nocturia means when the person has to wake up for passing urine, the sleep is disturbed because of urge to pass urine, and more than one time at night. So, if 2 to 3 episodes of passing urine and the urge to pass urine happens at night, that may be because of overactive bladder. Urinary incontinence is commoner in women than in men up to 80 years of age. And afterwards, things become same for males as well as for the females. The reported prevalence is 4 to 7 per 100 person years for the women. The 4 to 7 is the range from the different races, but this is underreported because this is an embarrassing situation. No one wants to disclose even to her partner. Sometimes get urinary incontinence while they are having sexual act. So, just going quickly about the bladder anatomy and physiology. As we know, bladder is just like a balloon which fills up the urine and holds it till the time we get an urge to pass urine and we find a suitable place. So, it's composed of detrusor muscles, internal sphincter, and external sphincter. External urinary sphincter is in our control, and internal sphincter is at the level of bladder neck. The internal sphincter is important for the stress urinary incontinence. At times, its position gets dislocated or that the supports get loosened. So, this plays important role in treatment as well. Or and neurological components, autonomic nervous system is important to study about it for the management point of view. So, SUI is primarily the disorder of urethral hypermobility or intrinsic sphincter deficiency. The blood supply, the nerve supply of the urinary bladder, the filling phase is under sympathetic control. The reduced sympathetic activation leads to detrusal muscle relaxation and sphincter closure. That is the filling phase. Usual volume is 200 to 400 ml, but bladder may distend up to 1 liter, may store urine up to 1 liter. Usually, up to 200 to 300 ml, the person gets urge to void sensation, and which is sent to brain via spinal cord. And once we get the feeling to pass urine, that is under the control of parasympathetic nervous system. And if we don't get the appropriate place to pass urine, even then we can control the urine with the help of voluntary somatic nervous nerves. And while passing urine, the detrusor muscle contracts and the sphincter relaxes. And the sphincter relaxes just 1 to 3 seconds prior to the detrusor muscle contraction. Means once the sphincter opens up and then the bladder starts contracting and urine is passed through it. So, coming back to the stress urinary incontinence, we will be focusing main on stress urinary incontinence, but at times the patient gets mixed incontinence or urge incontinence. So, some of the factors are common in both. So, we will discuss about management, which is applicable to both of the conditions. So, the commonest factor or the most important factor is the age. As the age advances, our support system of our tissues, with the age, we can guess a person's age by seeing the face. If we find someone is has the wrinkled face or there is this slackening of skin and the collagen tissue is less in her. So similarly, in the bladder area also, with the age, there is laxation happens. The support system, the support tissue gets weakened. Medical illnesses like hypertension, depression, and diabetes are very importantly associated. So, the sufferer of these medical conditions also are more likely to get stress urinary incontinence. Sometimes patient is on diuretics or smoking, obesity, and constipation. In obesity, the overall weight, the pressure on the bladder and the neck, that is more. And in constipation, the person is in habit of frequently straining. So because of that straining, there becomes a laxity of the or hypermobility of the bladder neck. Neurological causes may be relevant in this situation. If someone has neurological diseases, so the functioning and the control of system is disturbed, especially for the women, because this is the condition more or less associated with the women only. Very few male get the stationary incontinence. So in women, because inherently God has made this area weakened, because that needs dilatation in childbirth. The child has to pass through the pelvic the passage, and the urethra also passes through that passage. So those women who have undergone multiple deliveries, complex vaginal deliveries, instrumental deliveries, or the baby's birth weight was more, those conditions, tissue becomes damaged during childbirth, or if there is history of hysterectomy or genitourinary surgeries. And on physiological aspect, in postmenopausal women, because of age effect of aging, the tissues becomes hypoestrogenized and their support lacks. Because of that, there are chances of prolapse, cystocele, rectocele formation. So all these laxities are associated with stress urinary incontinence. So, how to evaluate? Our patient may present with the same complaint that I get urine leakage on strenuous activities, or when I get the urge to pass urine, I get urinary leakage. At times, when we examine our patients, we find the area excoriated and we get the smell of urine. In those cases, we can ask them, do you get these kind of symptoms? Even if they are not proactively telling us, but on direct questioning, patient may admit that she gets urinary incontinence. So for that, we need local examination, vaginal examination for laxity as well as for prolapse. For urethral hypermobility, we can do Q-tip test, and that is the if we apply just a stick, if the on straining the angle moves more than 90 degree, or the stick which was horizontal that becomes vertical, means the angle becomes upwards. That means the urethra is mobile, and the test is positive. Very simple, in easy way. What can we do in our OPD? When the patient's bladder is full, we just tell her to cough. If on coughing the stress test is positive, she leaks just 1 or 2 drops of urine, then the test is positive. In practice, we do it frequently. The cough stress test, that is enough to start treatment. Pad test. Even if our cough test is negative, then we give her a pad and tell her to do the coughing stenos activity, just walking. If there is leakage, that is also suggestive. Uh, if we have conducted all these preliminary examinations, if we don't find conclusive evidence that she is suffering from SUI, in those cases, we can go for perineal ultrasound. And while doing ultrasound, we should look for urethral hypermobility, or to rule out mixed incontinence, we can go for urethroscopy and urodynamic studies. These are more relevant if we are planning for surgical interventions. So the conservative measures which have been used for years, even generations are using these conservative methods. These are the traditional remedies. Lifestyle changes means one should avoid bladder irritants like use of caffeine intake, use of tea, coffee, soft drinks, even hard drinks too. Pelvic floor muscle training, which if done effectively, that gives a 60 to 70% improvement. Even after vaginal delivery or even after cesarean section. Vaginal delivery, this laxity is more common, but pregnancy per se is the cause of vaginal laxity or the risk of stress urinary incontinence, even if the patient has undergone cesarean section. So for all women, it's better to, whenever they come to you, just tell them to do the pelvic floor muscle training like the Kegel exercises, and we have to teach them the proper way of doing Kegel exercises. Patient can keep bladder diary for 3 days, and she should train her bladder. It's not like if you see a toilet, just go and pass urine. and after 2 hours you are finding a toilet available, you pass urine after half an hour. Then after 3 hours, in the meantime you don't get to pass urine. So we need to train your bladder that at a regular interval the you get the impulses that it's time to pass urine. So if we don't put very little urine in it and frequently pass it, or the more of urine is collected in it, maybe it's 300 ml, 400, 500 ml, and then we pass the urine. So all both the things are bad for it. So we have to train it for optimal timing and optimal urine output. So these are included in behavior techniques also. But if there is no response, then surgery will be recommended. So, but at times, if the surgery is done for one type of incontinence, the other type of incontinence may crop up. So that is why the surgery, although earlier it was said that it is the sure shot treatment for the SUI, but at times that may fail and worsen the patient's symptomatology. In those cases comes the role of non-surgical management of SUI. So, but for that we need proper counseling, and the because the non-surgical options may need repeated sittings for that to get the actual benefit of its good results. To my patients, I tell them you go to get facial or the haircut. All these treatments need frequent visits to the service provider, or even if you don't go to them, you have to do it frequently. So similarly, for this bladder training as well as for the non-surgical options, you should be very regular with the follow-up visits. So for counseling our patients, we have to compare the benefit, risk, and outcome of surgical versus non-surgical approaches. Remember, more than 60% of patients respond very well to traditional methods plus non surgical options. Only 30 to 40% may need surgical if they have increased severity of their symptoms. But at times, the surgery is not possible. Either patient is not willing, or her condition is not so bad that that can't be managed with the non-surgical options. So, for all these patients, needs informed decision, patient's preference, and her health status. Sometimes patient is unable to tolerate the surgical options, efficacy of particular modality or the combined therapy that must be discussed, and patient satisfaction and adherence to the non-surgical option is essential for the long-term success, especially in SUI, because as the age advances, our tissues become weakest, and with the age, we are very young, we can move fast, but as the age advances, our mobility decreases. The non-surgical treatment options are very patient-centered. So these are personalized, known to minimally invasive devices or therapies are used. No downtime. These are comfortable office procedures. Usually half to 1 hour sitting is enough for the maximum of the procedures. So for this, if we go to the pharmacotherapy, the commonly used is the duloxetine. But the imipramine can also be given, but which should be avoided in elderly patients. And the in my practice, I use duloxetine 20 milligram HS, and patients respond to it. Along with the all the conservative measures or Kegel exercises, we already tell them. And if age is more, so menopausal hormonal therapy is also given along with it. The duloxetine has very good results. It improves the urethral sphincter strength, but it should be avoided in liver diseases. Another important aspect of pharmacotherapy is if any patient presents with mixed urinary incontinence, either she has more of SUI component or UUI component, means urgent continence component, but we should treat urgent incontinence with the medical therapy with it, even if we are giving other modalities to her. So usually must be treated medically with the either anticholinergics like the the anticholinergics or beta 3 receptor agonists, or at times Botox treatment may be given to her. The anticholinergics, solifenacin or derifenacin can be given, and beta 3 receptors, mirabegron, can be given. But today we will just focus on the stress urinary incontinence. So if patient is postmenopausal, In those cases, as already discussed, that if estrogen deficiency is there, the tissue laxity, as our facial skin sags, after postmenopause, it starts sagging, loosening. Similarly, the vaginal mucosa as well as the urethral support system starts weakening because these have estrogen receptors. So, estrogen replacement therapy can be given. The easily available are vaginal creams. It is available in the form of vaginal ring and pessary or transdermal patch, or oral estrogen tablets can be given. But commonly used is vaginal cream, which is given 1 milligram per day for 8 weeks. In practice, we give it daily for 2 weeks and then twice weekly for 2 to 6 months, which gives a very good adjuvant role. So the adjuvant non-medical treatments are pads can be used. Incontinence pads are available for if someone gets occasional episodes of this. Along with other conservative measures, she can use the incontinence pads. And weight vaginal cones to strengthen the pelvic floor muscles can also be used. So nowadays the home devices are available, just a string with a vibrator and the programming. If that cone is held in vagina and that causes the frequent pelvic floor muscles contraction to strengthen it up. But this is the smaller device for single person use. But other devices are also available for clinic use. Uh, we can give the mechanical support to urethra, or urethral bulking agents can be used. Vaginal pessary has been used since ages. Since we were in our medical college days, since then we are seeing that vaginal pessarying is used for if patient gets mild to moderate uterine prolapse, or the cystocele is there, means the urethral hypermobility is there. In those cases, the pessaries, if these are well applied, patient may continue even up to menopause. I have seen a few patients, those who were given even after the means at the age of maybe 25, after their childbirth, they had laxity and urinary incontinence. Once the pessary is applied, they continued it till menopause. So the life is comfortable with that. They said that this is a real blessing that I was comfortable, I could do my job properly. At times, we need to give urethral inserts. Urethral bulking agents are available, which can be given in just periurethral area or just close to the internal urethral opening, that is the internal sphincter, and that helps control the urinary leakage. And other therapies are in the form of platelet-rich plasma or stem cell therapy or growth factor injections can be given at 3, 6, or 3, 6, and 9 position, and which also helps. But these things may need repeated injections. So these are the vaginal support passages. If patient has prolapse, then the if patient doesn't have prolapse, then the simple ring can be used. And if she has mild degree of prolapse and she wants the better control, then the fenestrated one can be used. The passages on the right side, the knob on this side, that is for the specific for the urethral support. So the pelvic floor strengthening with HIFM chair can be done. That gives the supraphysiological contractions of the pelvic floor muscles. Minimally invasive vaginal laser can be done. These leads to the first coming to the HIFM chair. That chair gives the half an hour sitting in which more than 11,000 supraphysiological contractions of pelvic floor muscles happen, as seen in this pic. And the 6 to 8, maximum up to 10 sittings are needed, which give the sufficient pelvic floor strengthening. And patient starts getting improvement in 1 or 2 sittings. From the even initial sittings, patient starts getting improvement. And at times, the touch-up or memory sessions may be needed after 6 months or 1 year. And the normally done the Kegel exercises, but this thing which is available, this is a real blessing because this is the comfortable one. Patient sits comfortably and gets the effective Kegel exercises with the machine. And once the vagina is lax and there is sagging, in those cases, the basically heat therapy is given. That is in the form of either laser or radio frequency treatment or uh, highly high intensity focused ultrasound radiations. So all these cause heating effect, which causes small minor damage to the uterine, to the vaginal submucosal tissue, and which causes the collagen regeneration and strengthening and tightening of vagina, as well as that supports the urethra and the bladder neck area. And this helps in control of stationary, even urge urinary or mixed incontinence also. So the earlier the surgeries were done, the like Birch Colpo suspension, the typical surgical procedure were there. But now a very good place is of mid-urethral slings. Different type of slings are available. Earlier the autologous slings were used, but now Marcelin tapes are used. Either retropubic, mini sling, or the transobturator tapes are used to support the bladder neck. So this is the high intensity focused ultrasound, which helps in vaginal tightening. And this device needs just 1 or 2 sittings, and the effect lasts for maybe up to 1 year or 2 years as per patient's comfort level. So what are the challenges and mitigation solutions for them? As we know, the non-surgical options need treatment adherence, and response is variable depending upon patient's tissues. Resource constraints may be there. That patient may say that I don't want to come again and again for the treatment. I will like to go for surgery because that is a one-time procedure. But if we want to avoid the surgery and its complications, so we should educate and empower our patients, and we should give them the supportive resources and tools. If we give them the bouquet of treatment that these options are available for you, and the combination of therapies is very good, and that gives equivalent results as compared to the surgical interventions, the patient's acceptance will improve. And above all, that is a collaborative care model. It's not only the role of gynecologist, it is the role of urologist, physician, plastic surgeon, even dermatologist. So if all of us are aware about the treatment modalities and we can educate our patients and guide them properly, that will give the best results. Thank you.
Thank you so much, ma'am, for this wonderful presentation. We do have some question if you like to take that up.
Okay.
Yeah. So, ma'am, the first question is, what is the role of urethral hypermobility in the pathopsychology of urinary incontinence?
The if urethra is hypermobile, so that will not. You can take it as if something has to contract, means we have to keep our sphincter, internal urethral sphincter needs to be contracted, so that should be in fixed position, so that all the efforts of nerves help in contracting it. But once it becomes hypermobile, it laxes from its position, so its contractility means the closing of that sphincter is disturbed with this because of its anatomical dislocation basically. If it was just behind the pubic bone and it was less mobile, means it was just restricted to it, so the closure of the sphincter was good. But if it changes its position, the angulation changes and the effect of closure is not effective, which causes urinary leakage.
Thank you, ma'am. The next question is, which patient group have the highest prevalence of urinary incontinence?
Women, first is women, and those who have undergone vaginal delivery, instrumental delivery, and the baby size was more, and those who have gone the gynecological surgeries, just like hysterectomy and all, because the support system is weakened in those cases.
Ma'am, there's one last question. When is a standing cough stress test indicate in the evaluation of urinary incontinence?
In those cases in which, because that is this position, standing and sitting position, these are the position in which we get the urinary incontinence commonly because of anatomical position of our urinary bladder and urethra. So if on lying down we are unable to generate it, then ideal is that to get it done in the standing position. But if we get
Thank
the
you.
same result in patient is lying down in front of us and we are doing PV examination and we find the urine leakage, then it's positive. But if we are unable to get it, then best is to get it done in the standing position.
Thank you so much, ma'am, for answering all our questions. That's all from our audience. So, ma'am, before concluding, any take home message from your end?
Uh, I will suggest, because every woman means most of the women have to age, even if you have not undergone any childbirth. Even then, because of aging, the vaginal laxity is there. So we should strengthen our the pelvic floor muscles with the Kegel exercises, the proper Kegel exercises, as I had shown in one of the figure. And even for childbirth, vaginal delivery is good because that is the natural process. We must educate our patients about the pelvic floor exercises after delivery. And the device, the HIFM chair, I have discussed about it, so that we can give the rehabilitation therapy after the delivery, after the childbirth. As early as 6 weeks after delivery, patient can take 4 to 6 sittings of that chair. That will be very effective for strengthening our pelvic floor, and that will have long lasting effect, because that is the phase of recovery of changes, the postpartum changes, recovery of the pelvic tissues. So in that phase, we should do the rehabilitation therapy also. So that we are doing in our practice. We have this chair and that is giving us very good results. So we educate our patients that this is very important. If our pelvic floor is strong, even if you go to gym and even if you do the heavy weight lifting exercises, you will not leak. That is an assurance.
Thank you so much, ma'am, for joining our platform. It's our pleasure that you have joined us for today's session. With your permission, ma'am, I would like to conclude today's session.
Thank
Thank
you.
you, ma'am.
Thank you.